Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Year in Review. As today we talk about key data sets and presentations over the past year in the field of melanoma and non-melanoma skin cancers. We have a great faculty today, Dr. Omid Hamid from the Angeles Clinic and Research Institute, Cedars-Sinai affiliate in Los Angeles, and Dr. Evan Lipson from the Johns Hopkins School of Medicine and the Sidney Kimmel Comprehensive Cancer Center. As with all of our webinars, if you have any questions or cases you'd like to run by us, just type them into the chat room and we'll talk about as many of these as we have time. We have a quick 1-minute survey for you to take before and after the meeting. If you take that, it'll help us learn a little about you and you'll get a little more out of this meeting. We know a lot of people end up listening to our webinars. If you're into podcasts, check out our Oncology Today podcast series, including a program with Dr. Hamid on melanoma. We do webinars all the time. Next week, we have a really interesting one on bispecifics and myeloma. Then on Thursday, we'll be picking up on a very hot topic from this past ASCO meeting, ER-positive metastatic breast cancer. And then on the following week, July the 25th, we'll continue our soft tissue sarcoma and related connective tissue disease program. And then on the 27th, we'll be talking about HCC, hepatocellular carcinoma, all the debate about optimal first-line therapy. On the 31st, we'll be talking about high-risk hormone-sensitive non-metastatic prostate cancer and the gigantic EMBARK study that was just presented in the last couple of months at the AUA meeting, talk about what that's all about. And then another program on bispecifics, but this time in non-Hodgkin lymphoma in the beginning of August. But today we're here to talk about a topic where there's a lot going on. As in all of our programs, I met with the faculty separately to record their presentations. So you have both Dr. Hamid and Dr. Lipson, extensive presentations going through many data sets and a lot of different concepts. Today, we're going to focus on a few of those and some of the more important general issues that were discussed. You can see there are a whole ton of papers that the faculty went through, and it's really well worth your time to go through these. Today, as I said, we're going to kind of see if we can take some of this to the next level. And here's where we're heading today. I just had a few thoughts I want to run by the faculty in terms of immunotherapy of melanoma. And then we'll talk about some of the big papers of the year in melanoma. Then we'll get into cutaneous squamous cell, basal cell, Merkel cell, and finally a whole bunch of really exciting novel agents and strategies. We won't be able to talk about all of them. We're going to pick out the highlights. So I just want to start out. It's just kind of a general thought I had that I was kind of running by the faculty before we got started. Kind of thinking about the responsiveness, because when Omid went through his talk, he was going through all these new strategies. He was saying melanoma is really taking a leadership role in, sort of demonstrating to other solid tumors what can be done with immunotherapy. And Omid, I was thinking a little bit about, we talk about, checkpoint inhibitors, immunotherapy almost every day, it seems like, but trying to put in perspective. And the more and more I was thinking about it, I was thinking about suppose you could put up a scale of responsiveness to checkpoint inhibitors. And on one end, you have unresponsive tumors, at least right now, breast cancer, prostate, for example, ovary. And the other end, in my mind, at least what we talk about a lot with solid tumors, is MSI high disease. And the more I was thinking about it, because I was listening to what you were saying about melanoma and thinking, well, would that apply to lung cancer? And I was thinking it sounds more in a way like MSI high, where most of the patients respond. You were talking about the dramatic improvement in median survival that we've seen with melanoma going from 6 months to 6 years. And I think a lot of that is immunotherapy. But Omid, maybe you can kind of put in perspective how along that line where you see melanoma and then some of the other solid tumors, lung, renal, et cetera, in this spectrum of current responsiveness.
That's a great question. I would tell you that, the most responsive tumor to checkpoint inhibition is desmoplastic melanoma, response rates of 70% and long-term durability. So what we're looking at is high response rate, durable response. And on the higher end there are Merkel cell, cutaneous squamous cell, basal cell. In addition to that, we have the melanomas that are there, followed by renal cell carcinoma. The data from microsatellite and unstable tumors, and the most recent rectal neoadjuvant data. And then towards the middle, there are the lung cancers, the ovarian cancers, the GI, esophageal, gastric, and other. What we're finding there is we're getting response rates. They're lower and they're less durable. So to turn it on its end, I would say it's the fact that we're trying to find out why certain melanomas are responsive, trying to find those same predictive markers in other solid tumors. And then in those tumors that don't respond, working to get the higher response through combinations or a priming or boosting type of mechanism.
So I'm curious, Evan, Hopkins, which I'm proud to say is my alma mater as well. I'm actually from Baltimore, has certainly had a huge leadership role in immunotherapy, particularly checkpoint inhibitors. And I'm curious, over the years, of course, we've been debating, how do you figure out why some tumors respond better than others, PD-1 levels, TMB, et cetera. Where are you today with that, Evan? Any thoughts about sort of this idea of the spectrum of responsiveness that we're seeing right now in solid tumors?
Yeah, that's I think a good summation. We're seeing this spectrum of responses, and in some studies there is a correlation between higher tumor mutation burden and response. There was one study out of Memorial Sloan Kettering that looked at female patients specifically had a higher likelihood of response when the tumor mutation burden was over 10 mutations per megabase. So there certainly is evidence in melanoma and some of the other tumors that higher TMB equals higher likelihood of response to immune checkpoint therapy. What Omid said a minute ago about needing something additional for the lower tumor mutation burden set, I think it's an excellent observation, and that is exemplified by what we've seen recently in uveal melanoma. So uveal melanoma is very low tumor mutation burden, and immune checkpoint inhibitor therapy has very little activity. But when you apply a bispecific antibody like tebentafusp, for example, you are seeing benefits in overall survival. So it may be that for lower tumor mutation burden tumors, a simple PD-1 blocker or CTLA-4 blocker is not the way to go, but rather you need for example, bispecific antibody to bring a T cell in close proximity to a tumor cell.
So actually, Camel in the chat room wants to know, Evan, what your cutoff is for low and high TMB. Do you buy into the 10? Do you even look at that in melanoma?
Yeah, it's a good question. I don't know that there's an absolute accepted definition, but for what high TMB really means, some studies use 10, some use 15. We don't look typically, other than for academic reasons. But I don't not prescribe immune checkpoint therapy if somebody's TMB happens to come back at 4 or something like that.
All right, well, let's go through some of the key papers from this past year and also touch base about where we are in general in some of these tumors in terms of key management issues. And of course, one of the things that you talked about, Omid, relates to the issue that's been out there for a while of what comes first in the BRAF mutant situation, BRAF therapy or immunotherapy. And maybe you can just comment. I don't want to show a million slides tonight. I more want to hear the two of you talk about it. But clearly, the DREAM-seq trial, Omid, really solidified the role of immunotherapy up front. Can you talk a little bit about what was seen in that trial and what your thoughts are about it, Omid?
Sure. I think it's important to look at DREAM-seq as what it gave us is for all comers. You start with immunotherapy, that's arm A, or targeted therapy, that's arm B, and then what happens when you switch over. And this trial clearly showed that progression-free survival, overall survival improved. Here's a survival plots here. So it's important to show you need to start with immunotherapy combo when you can. And you can see here some of the survival, it flips. There is a certain subset that cannot tolerate combo immunotherapy. Is that because the disease is rapidly progressing, they're symptomatic, or they don't have time? And so the next one, Succumbit, gave us a little bit of an answer to that. And Succumbit was 3 arms. The first arm was starting out with just targeted therapies until progression, and then going to combination immuno. The second arm was immuno combo to start, then to targeted. And the third was what we call a sandwich, just 2 months of targeted therapy, BRAF MEK, and then based on control, switching onto combination immunotherapy. And what it showed was either the sandwich or initial combination immunotherapy were better than targeted therapy. Now, the EORTC is doing a randomized trial of the sandwich type versus just beginning with combo immuno, and we'll find out. But for me, that says we can use combo immuno to get these long-term benefits. And in those patients where I have concerns about the rapidity, I can use some initial form of BRAF inhibition and then go to immunotherapy. Now, this is a small study, but what it will give us is what Dr. Lipson was pointing to: predictive markers, circulating tumor cell assessment, and help us to plan that map for our patients who have BRAF mutations better.
So, Evan, any thoughts about the study? And also, one of the things that Omid got into with the DreamSeq, and I'm curious what your thoughts are. I see if I can remember this correctly, was the idea, tell me, I think I have this right, that when you start out with targeted therapy, the response to immunotherapy in the second line is not as great. Do I have that right, Omid?
That was right.
And
when
that's
they
where
looked at, right, when they looked at the response rate. Yeah, when they looked at the response rate post failure of initial targeted therapies, it was not equivalent. It was not what we expected. And the question is, were those the patients that were progressing too rapidly, or is there a signature? Is there a resistance that happens to immunotherapy when you become resistant to BRAF therapeutics?
So, Evan, I'm curious about your thoughts about the trial and also that phenomena or the observation that Omid was just talking about. Any reason to think that targeted therapy prior to immunotherapy has some type of effect to make immunotherapy work not as well?
Great question. My interpretation of the DreamSeq data was sort of a practice affirming one, where we've been using IPI plus Nivo typically upfront in patients rather than using targeted therapy upfront. And so it was good to see that there was some data behind what was our practice. There are a couple of important caveats. One is what you brought up, which is it possible that we are inhibiting the ability to mount an anti-tumor response by starting with BRAF MEK inhibition? I don't know. That's a little difficult to say. There is some evidence from Jen Wargo and her team that you're actually augmenting PD-L1 expression when you administer BRAF and MEK, which would suggest that you're perhaps augmenting the body's ability to respond to anti-PD-1. If you look at the triple therapy data, the like Atezo, Vem, Cobi data, PD-L1 plus BRAF and MEK, you do seem to get a little bit more when you add those 3 together versus just the 2. But having said that, anecdotally, we, I think, have all seen patients where we try to switch from the 2 targeted agents over to IPI plus Nivo, and it's just really hard to get those patients to respond. And I think that's DreamSeq demonstrated that in a large study.
So before we go on, Omid, Dr. Malady in the chat room has a case. I'm just going to read it to you. I'd like to get your input on a 38-year-old man I saw this week. He went to urology for a vasectomy, but he brought to the urologist the attention of a small melanotic skin lesion close to the midline on the scrotal skin. Had excision and path showing nodular melanoma, T4B, 7.5 millimeters thick, margin negative, but not enough. Waiting on WLE and SLN and PET, BRAF pending also. But any thoughts about this rare situation? You're not going to tell me you've seen 5 of these, but I'm just kind of curious.
No, I think I've seen 1 or 2 of these, and that it's skin. It happens. I'd probably want to review the pathology to ensure the appropriate diagnosis and treat it like I would any. Now, thanks to Dr. Luke et al., we do have options for what seems to be a 2B or a 2C melanoma at the very least for adjuvant treatment. And I would, agree with the staging done and the wide excision and sentinel procedure. Now, it seems like you're not feeling any nodularity or any in-transit or any nodal disease. If this was more of a bulky stage 3, then I would move on to some form of neoadjuvant process for this patient.
And, it also brings up, I know there's really encouraging data coming out on neoadjuvant therapy. Evan, right now, any situations where you do use neoadjuvant therapy, and where do you see that heading?
There are, yeah. I think neoadjuvant therapy is finally ready for prime time. There are, I would say, more situations now where we are considering it in bulky adenopathy, resectable disease. As Omid suggested a minute ago, if you palpated adenopathy in this patient with the scrotal melanoma, I would consider it in those situations. I think of that patient population, there are more patients where we're thinking, let's go neoadjuvant versus not. The question, of course, is what do you give and how long do you give it? And then after you're done giving it and the patient goes to the operating room, do you need to give adjuvant therapy? And we don't really have solid answers to any of those questions. We try to pick the particular neoadjuvant regimen based on the overall health of the patient, the same way we do with metastatic disease. But it would be great to have a biomarker to say this patient needs 2 doses of IPI plus Nivo at low dose, and then that's it.
And Dr. Malady says there's no palpable adenopathy or other lesions. So let's talk a little bit about first-line immunotherapy and also some of the new data that's coming out with LAG-3. First, Omid, you reviewed this update to the Relativity 047 study with relatimab. Can you kind of talk, first of all, in general, about how you think through first-line immunotherapy in general, Omid, and what situations are you using this as opposed to IPI-Nivo or even single agent?
Yeah, a great question that has a lot of tentacles that come out of it. So first and foremost, for me, a first-line patient that presents, we make sure the full workup is done, MRI the brain and full staging. Secondarily, clinical trials. Understand that we're making huge leaps forward based on these clinical trials. So we'll go from there. Now, that's not the majority of patients that show up in a clinic elsewhere or for patients who cannot go on to trial. I find the data of nivolumab plus relatlimab versus nivolumab to show a greater response rate, a modicum of increase in toxicity that's manageable, and progression-free survival benefit. Now, this was done in a randomized blinded fashion, and the updates show that those benefits are there. The overall survival benefit has not become statistically significant, but what I see here is what I've seen with any other checkpoint inhibition in melanoma. At 3 years, you're starting to see a plateau on the tail of the curve. So there is benefit. Where does this fit in for me? There are clearly patients who come in who need combinatorial therapy, and Checkmate 67 puts Nivo IPI in the 4 for those patients. What are they? BRAF mutant, from Checkmate 204, brain metastases. Their liver metastases at this point, there isn't head-to-head. If you want to do a head-to-head, a very wise man named Vern Sondak once told me to take a look at the hazard ratios because they're both randomized to the same control arm. And you can see here BRAF mutants falling out, favoring one, and then the rest are similar, almost similar. Where we haven't really made a lot of headway is understanding where these combinations fit in with patients with PD-L1 expression over 1%. And that we clearly need better regimens that show a better hazard ratio there. For me, I think Rela, Nivo, and combinations are going to move to the 4 because we're treating more and more patients in the adjuvant setting with single agent PD-1. And if they relapse, recur, the data that we have, although it's very small, shows low response rates. Now, I presented some data with fianlimab, cemiplimab, which was LAG and PD-1 in those patients who have failed adjuvant PD-1 therapy, and the response rates were greater than 50%. So I think in those populations, they come to combo. Great. This slide brings up a greater point. What about toxicity? In the past, when we gave single agent PD-1 versus CTLA-4 PD-1 therapy, our concern was toxicity. And as you can see here with the relativity 47, the grade 3 to 4 toxicities are low. They're usually manageable. And therefore, for those patients who have possibly a poor performance status or age or cardiopulmonary issues, I tend to go more towards Rela-Nivo as an approved regimen in combination.
Evan, any thoughts on what Omid just said? The idea of prior adjuvant therapy is very interesting. Obviously, the closer you are to that relapse, the more concerned people are going to have. Incidentally, do we know in the BRAF positive patient, let's say who gets adjuvant IO, again, do you still start with immunotherapy, or, if the recurrence is, let's say, a year after, would you maybe think more about targeted therapy, Evan?
Good question. So the recurrence issue is a tricky one, both in terms of response rates and also time after therapy. So let me tackle one at a time. In a PD-1 refractory patient, we, as Omid alluded to, we're seeing a 9 to 12% rate of response when you administer relatlimab plus nivolumab in those patients. So not high, it's a small but real rate of response. That rate of response is higher if you use IPI plus Nivo. There was a study done a few years ago in the PD-1 refractory set looking at IPI plus Nivo versus IPI by itself. IPI plus Nivo was the winner in that study. And so response rates are in the 25 or roundabout ballpark. So with regard to what you would expect the response rate to be in a PD-1 refractory population, there, I think, is probably a difference between Rela-Nivo and Ipi-Nivo. The second issue is with regard to how long a patient has been off of therapy. So if a patient's been on therapy for a time and has a response and then is off of therapy, say for a year, you could give reinduction anti-PD-1 monotherapy all over again. And in some cases, you will expect a response. However, it didn't knock the ball out of the park the first time around. And so I don't think I would expect it to do that the second time around. And in those cases, in general, we're switching to combination therapy in an effort to not just sort of push the immunologic pendulum back where it might have been initially and mount an anti-tumor response, but we're trying to solidify that tumor response so you get more durable anti-tumor efficacy.
So, Omid, another thing that you got into that was really interesting was the issue of another LAG-3 antibody, fianlimab. But what I found really interesting when you went into this is not dosed the same. There's an innovative approach to dosing here. Can you talk about this agent and what we know about it at this point, Omid?
So fianlimab is an IgG4, a LAG-3 antibody. It's a different manufacturer. Their combinatorial phase 1 got them to this dosing. It's about a 10 times greater dosing, and the frequency is every 3 weeks versus every 4 weeks with the relatlimab. Now the question really is this a true benefit that we're seeing? Some of the highest response rates in about 100 patients that were presented here at ASCO in this presentation you see here, the response rates are over 60%, whereas you're seeing response rates of 44% with Rela-Nivo. But when you put up the next slide that shows the head-to-head comparisons, the numbers are really not there. It's 98 patients. But this is not some of the other trials where you got response rates in the 50% and then randomized trials. showed no benefit. We know that this target has benefit. We know we're dosing higher. And what we also know is with relatlimab, there are studies in single agent where they have dosed much, much higher, almost 800 milligrams per dose. So this is the randomized 3 trial that's accruing right now, not only to see what's going on. There are 2 different fianlimab doses here. So you'll see whether there's a dose response. And it's also looking in combination, in single agent pembrolizumab and also single agent cemiplimab. So it'll probably tell you what we've known is that the PD-1 antibodies are pretty much the same.
So before we get into some of the things we covered with localized disease, let's take another case from the chat room. So Evan Samar has a 26-year-old T4A N0, 18 millimeter thick nodular melanoma in the forearm, deep margin close to the muscle, 1 millimeter, no Mets. Patient will get adjuvant immunotherapy, ? Margins are close. The plastic surgeon will attempt for wider margin, cutting muscle without major functional limitation on the use of the hand. Any role for radiation therapy for close margins, and any thoughts in general about this case, Evan?
Good question. That is a really thick melanoma. You said it was nodular, so typically we're not using radiation therapy as adjuvant in patients with nodular melanoma. That does come up occasionally in desmoplastic melanoma. I think adjuvant therapy is potentially appropriate depending on what else is going on with the patient. The surgical margins really are more a function of what the surgeon intended. Intraoperatively, is there a 2 centimeter margin around the specimen, around the tumor? If there's a question about a close margin at the deep aspect, then re-resection there may be appropriate. But in terms of the peripheral margins, it's really during the operation that we're concerned about what the surgeon has in mind.
Anything you want to add to that, Omid?
No, I think he's done a great job in presenting it.
So these are some of the papers that you went through. Both of you went through various papers in terms of localized disease. Of course, the paper that you talked about from the ImmuNed study, looking at Nivo alone or combined with ipilimumab, gained a lot of attention. Omid, I'm not going to show the slides, but can you just summarize the bottom line there and what you thought about the study?
Yeah, I thought it was a great study that it answered certain questions and also brought up certain questions in the stage 3 adjuvant setting. Number one, Dirk Schandorf and others looked at adjuvant Nivo or Nivo-Ipi versus placebo in stage 4 resected melanoma. In the past, you tended to watch these people, and then with the approval of nivolumab, gave nivolumab in the adjuvant. And with certain adjuvant stage 3 trials showing a failure of Ipi-Nivo, this one took full dose Ipi-Nivo. It's important to note. Why didn't we do it in the stage 3 adjuvant? Because we didn't know if these people would progress. But in the metastatic setting, the stakes are higher, the risks are higher. And this showed not only progression-free survival advantage, but overall survival advantage, which indicates that it isn't really true that there is an adjuvant in metastatic melanoma. It's metastatic, and there's a huge risk to patients. And this has become a standard for me, combination adjuvant in stage 4 resected melanoma.
Evan, anything you want to say about Checkmate 915 and also the 2 studies you reviewed looking at adjuvant immunotherapy with stage 2B and 2C disease?
Sure. So Checkmate 915 is an interesting study. As Omid alluded to, the stakes are a little bit different when you're talking about truly adjuvant therapy, which means that you've resected disease with the possibility of cure. And that really is unrealistic in somebody who already has stage 4 disease. Not entirely impossible, but largely unrealistic. So the Checkmate 915 was a look at whether Ipi plus Nivo could improve outcomes in patients over and above nivolumab by itself. And it did not. Not only that, the toxicity was higher with nivo plus ipi, as we've seen before. It did use a low-dose ipi, 1 milligram per kilogram every 6 weeks. So the question, of course, always comes up, well, what if you could use standard dose ipi? Unclear if that's the case. But in any event, anti-PD-1 monotherapy is still the standard adjuvant for patients with resected stage 3. I agree with Omid that for stage 4 disease, we are leaning more toward ipi-nivo for the reasons that Omid described. The second one, pembrolizumab versus placebo as adjuvant in 2B or 2C, that has now become the standard. And it is possible that nivolumab will be added to that list. The PDUFA date for nivolumab in adjuvant stage 2, I think, is October, middle of October of this year. But the results from the Keynote 716 study and from Checkmate 76K look essentially the same, which is that there's a relapse-free survival benefit for anti-PD-1 in patients with resected stage 2B or 2C. So I think for now, until we have a targeted therapy option for BRAF mutant patients, the anti-PD-1 as a single agent remains the standard for adjuvant resected 2B and 2C.
Evan, how do you decide whether to use immunotherapy or targeted adjuvant therapy in stage 3 in patients who are BRAF positive?
So for the lower risk patients, I generally lean toward targeted therapy. The reason for that is, as Omid suggested a little while ago, there is a chance that you have surgically cured somebody after resection of a stage 3A, for example, or 3B, or even in some cases 3C, but the lower stage 3s, the possibility of surgical cure is real. And so if that's the case, if you in fact have removed every cancer cell from that patient's body, if you're giving them immunotherapy or targeted agents for that matter, you're only giving them the toxicities of that therapy. They're not getting any benefit. So the likelihood of a long-term permanent toxicity is probably higher with an IO agent than it is with a couple of targeted agents. So for that reason, I generally sway toward giving somebody targeted therapy when I can in the adjuvant setting. But you know, this is a patient specific conversation with everybody who walks in the door. Some folks are really excited about getting adjuvant therapy and don't want anything to do with pills every day. And some patients are the opposite.
So a couple more questions from the chat room. Omid, Dr. Kumar wants to know, do you use 1 milligram of IPI or 3 milligrams of metastatic disease? I'll start with that first. That's a quick one.
So he's pointing towards Checkmate 511 that looked at flip dose ipi-nivo, and that was one done only for toxicity. You know, the overall survival and progression-free survivals look the same, but the numbers weren't significant enough. I use full dose when I can. I absolutely use the standard ipi-3-nivo one for brain metastases, BRAF mutation, and hepatic metastases if I can. Also mucosal and ocular melanomas, there's no data there with the flip dose. If there's someone I want to avoid the toxicity, but I want to give ipi-nivo, then I'll use the flip dose.
So a couple more here. Maybe we might spend the rest of the time just on the chat room. There's so many things coming in here. So as is true of all the solid tumor webinars we do, I know somebody was going to ask about ctDNA. So Lee brings up the issue of Evan, ctDNA and adjuvant therapies is now utilized routinely in colon cancer. What about in melanoma, Evan?
Yeah, it's a great question. I wish that it were as helpful in melanoma as it is in colon. There are certainly trials. We have one of them looking at the utility of bespoke ctDNA assays in patients with resected melanoma or treated melanoma. But for right now, it's not ready for prime time. There is evidence that in the ocular melanoma set with tebentafusp, that ctDNA can be an indicator of success. The imaging characteristics of ocular melanoma aren't always the clearest. Even in patients that progress on imaging, they still have an overall survival benefit. So ctDNA there may be a better indicator of how somebody does. But for the cutaneous set, we're not quite there yet.
I mean, I just want to step in here and say the following, that ctDNA is only useful if you know how to use it. In the adjuvant setting, you have to ensure that you do a pre-surgical ctDNA because the majority of tumors don't express that in melanoma. And in those that do, if the ctDNA goes to undetectable versus those that have detectable post-resection, your outcome is better. And that has been shown, although in smaller numbers, in some of our adjuvant trials, including the Moderna trial and others. So if you know how to utilize it, it's helpful. It is absolutely not the answer to anything at this point.
So check out Evan's talk. We were talking about neoadjuvant therapy. He reviewed a paper in the New England Journal looking at that. Really interesting with the advantage of neoadjuvant therapy. We already talked about the phase 3 trial looking at the anti-LAG3 agent fianlimab with cemiplimab that's in progress. Also an adjuvant ENCO-BINI's trial, which I think will be much looked forward to. I'm going to ask Evan in a second about this other amazing paper, but first, another quick case. Back to you, Omid, from Dr. Rudolph. 72-year-old patient, stage 4 BRAF positive tumor progresses on cycle 3 of ipi-nivo. Now switch to ENCO-BINI. If he progresses or she progresses, what's next?
Right. So what's next is adoptive T-cell therapy. If you look at the data that was presented in the New England Journal by John Hannon and Associates, 48% response rate. If you look at the data that's been published in JCO with Iovance, 31% response rate. It's a one-time therapy. Now, that may be a 74-year-old that has cardiopulmonary issues. If it's a 74-year-old in LA, it's like a 50-year-old body, but might be an East Coast 74-year-old. Then you can check HLA status and look at the data that come from, that was presented at ESMO in regards to the bifunctional PRAME antibody from Immunocore. There's data from tebentafusp showing response rates and great one-year survival. So looking for that. There are multiple clinical trials of newer targeted agents, whether you're looking in the tumor microenvironment plus PD-1 versus other, and K-cell trials are upcoming. So for this guy, the next thing is clinical trials. Not to also say that my focus is a lot on immunotherapy, but there are newer drugs that are utilized in BRAF unresponsive tumors or BRAF progressive tumors. One of these was the Novartis drug, the LXH trial, showed responses not just in BRAF failure patients, but NRAS mutant patients. So there is a ton of clinical trials of better or the next generation of BRAF inhibitors that are out there.
So yeah, that's really interesting about these next generation BRAF strategies. So this is the one, Evan, when I saw this slide in your deck a couple weeks ago, and that night we had a webinar on bladder cancer. And I started the webinar with saying, look, before we talk about bladder cancer, I got to tell you about this paper I just saw that I was not aware of, because I was amazed. This is this adjuvant study, randomized phase 2, looking at Pembro plus an mRNA virus made by a company named Moderna you might have heard of before. Evan, can you just sort of summarize briefly? And I didn't even realize that Moderna originally was focused on cancer before they got into the COVID world. Evan, we could talk about this a long time, but bottom line, any thoughts about it?
Sure. Briefly, this was a study that enrolled patients with resected stage 3B through 4 cutaneous melanoma. They randomized those patients 2-to-1 to either receive the mRNA vaccine, which is what you mentioned. That is a bespoke vaccine. It was designed for based on each patient's tumor individually, plus pembrolizumab, and the control arm was pembrolizumab by itself, which was the standard dose of pembrolizumab given for a year. And the primary endpoint of the study was relapse-free survival. The reason the statistics here are in a red box is because there was a lot of discussion about whether the way the stats were set up, including a one-sided alpha, was appropriate, et cetera, et cetera. However, if you take all the findings together, what we see is that compared to Pembro by itself, the vaccine plus Pembro led to a 44% reduction in the risk of recurrence or death and a 65% reduction in the risk of distant metastases among this patient population. So as I say, the statistics are borderline. If you go back one slide, you'll see that some of the stats are, it's not a slam dunk. But these curves separate enough so that there's excitement about whether this could be, an effective combinatorial therapy. So there is a phase 3 trial that should be opening up very shortly.
So any thoughts about this, Omid? The thing that really amazes me is the bespoke nature of it, that they individualize it, I think, to 34 neoantigens from the patient's tumor, which sounds pretty interesting and maybe expensive, but any thoughts about that?
Oh, yeah. If you look at this trial, there's a lot hidden in the PFS curves, because the PFS curve on the Pembro looked similar to what we've seen in the Pembro versus placebo. And then if you look at what the vaccine gave, it was a little bump higher. And that's great in melanoma. But as I tell you, this is something that is translatable into multiple solid tumors. Let's just take lung cancer, for example. If you have a lung cancer and you're stage 3, what's the standard now? Chemoimmuno neoadjuvant. If you get a CR, you do phenomenally well. What if you don't get a CR? Well, there you are. You got a bunch of tumors sitting in your pathology department, and you're going to give them Pembro or Nivo or some PD-1 anyway. Why not bump up their response? So I think the success in this only pushes this type of approach forward in other solid tumors, and the main power of it is going to come in the place where it can prime and boost immune response, and that's in the adjuvant setting.
So I'm going to try to tear myself away from melanoma and get into some of the other cancers, but I just have one more case from the chat room, Evan, from Hassan. 40-year-old man resected melanoma a year ago, now has a lung nodule that's resected, metastatic disease, no other sites of Mets, BRAF mutated. So I would call it pseudo-adjuvant therapy if you're going to treat a patient like this. Would you treat this patient, Evan?
Yeah. So he's metastatic but resected as far as we can tell.
Right.
Yeah, I'd get a brain MRI and see if anything's going on intracranially. And depending on this patient's performance status and history of autoimmunity and such, I think it's reasonable to consider systemic therapy for this patient. As we were talking about before, the Immuned trial suggests that Ipi plus Nivo may actually be helpful in a case like this. If you wanted to dial down the toxicity a little bit, you are likely going to have, as I like to say, 2 shots on goal, meaning you're going to have time to give one therapy or combination therapy, and then if you need to, sort of turn up the heat. So I don't think it would be wrong to start with single agent anti-PD-1 or relatlimab and nivolumab, and if you needed to, you could increase to Ipi plus Nivo.
So Omid, let's talk a little bit about cutaneous squamous cell. Evan reviewed a bunch of new papers that we're going to talk about in a second, but you kind of provide an overview of the kinds of clinical situations that you see, that medical oncologists see with squamous cell carcinoma, and where we have been in the past in terms of systemic therapy, particularly immunotherapy.
Yeah, I tell you that it's an interesting revolution in the care of the non-melanoma skin cancers, as we saw a few advanced cases in the past because we didn't have options, and few advanced cases I would say that would be basal and cutaneous squames. The patients that I see in my clinic are the ones that come in that have either multiply recurrent disease, that's the approval, right? Not amenable to surgery or radiation. So it's something that you look at, I could cut that out again, but it's come back 3 times, or it's in a place where I can't cut it out and radiation is toxic. That's one. And then more often I see people who have these cutaneous squamous cell carcinomas of neglect, where they become invasive to the point where you cannot resect without being morbid. But they may have very rarely local nodes, which is considered metastatic in any respect. So immunotherapy has come to the fore because we have seen high response rates and durable response and tolerability in a subset of patients which are usually not the best. They're usually older. They usually have comorbidities. They usually are, some of them, patients who have neglect and they're not healthy. What it's also allowed us to do is utilize this as a springboard to other immunotherapies that have shown benefit in melanoma. I have seen and utilized oncolytics in these cases of these patients and have published in patients who have been post-transplant and could not get onto a PD-1 type of therapy or checkpoint therapy, and local injections of drugs such as the TVEC, which it's not approved for, but oncolytics through clinical trials have shown significant durability of response. Now I see here you've talked about cemiplimab for kidney organ transplant recipients, and we're sort of becoming more comfortable in these cases. But what this field of basal and squam has shown is immunotherapy has high response rates. These squams have the highest tumor mutational burdens ever seen. And higher than those are those patients that are immunosuppressed who get cutaneous squamous cell carcinoma. So we have to force immunotherapy into their therapeutic paradigm.
So, Evan, here are some of the papers that you reviewed on this topic that came out this past year, and a bunch of them related to cemiplimab. Can you kind of summarize what we learned from these studies?
Sure. That first one there is the phase 2 study of cemiplimab in patients with advanced cutaneous squamous cell. And this is just a long-term follow-up of this cohort. So the patient populations were broken down into two categories. One was locally advanced squamous cell. The other was metastatic squamous cell. And as you might expect, the locally advanced patients tended to do a little bit better than the metastatic set. But in any case, the curves go out quite a ways. I think the median duration of follow-up was something like 16 months, and the median overall survival had not yet been reached. As Omid suggested, the response rates are really high, and the durability of the responses is quite long. I think more and more we're moving into the neoadjuvant space in cutaneous squamous cell carcinoma, similar to the melanoma space. And the New England Journal paper by Gross and colleagues demonstrates a 51% major pathologic response rate in patients that got cemiplimab for a resectable cutaneous squamous cell carcinoma. So again, I think that's probably ready for prime time in the setting of a multidisciplinary evaluation. Is a couple of few doses of anti-PD-1. In this case, cemiplimab was used, followed by surgery. And then the question remains, in somebody, say, with a path complete response, do they need to get adjuvant therapy? And then finally, the cemiplimab for or kidney transplant recipients. This is a fascinating story by Glenn Hanna and his colleagues up in Boston. He looked at the use of cemiplimab plus an mTOR inhibitor in kidney transplant recipients with cutaneous squam. The risk there, of course, is organ rejection, transplant, allograft rejection. He did not see that among the dozen or so patients that he treated. And the response rate was about what you see in the general population. I think it was in the 50% range or so. So we're trying to thread the needle and find that specific combination of immune suppressive and immunoactivating therapy you can give to these organ transplant recipients to keep the allograft healthy, but to allow the immune system to attack tumor. So this is a great first step.
So Omid, from back to the chat room from Ankit, who has a 57-year-old patient with CLL that required ibrutinib for 9 months, and has metastatic cutaneous squamous cell, has progressed on cemiplimab, no targetable mutations. Any thoughts about either off-trial therapy or any exciting trials that might be considered?
So if it's a local, I would think about some type of local and injectable, et cetera. But if for my patients with CLL, whether they have squam or melanoma or other, I would move them on to another type of immunotherapeutic clinical trial. Now, there's data that's been published about utilizing CTLA-4 and PD-1. LAG3 is expressed on multiple solid tumors. So I'd look for some of those trials. There are a multitude of trials looking at LAG3 and PD-1, and I'd look for that. We have a bifunctional antibody that expresses both. The patient could go on to that trial. And so there's a lot of clinical trials available for these patients.
Incidentally, Omid, what happened to TIM3?
It's still around. It's being looked at actually in the adjuvant setting, in melanoma and others. But my impression in some of these are that they can't do the heavy lifting, so they cannot work alone, and they may not be best suited for the refractory or relapse setting. And then you can look for optimal combinations in first line. For example, we are accruing to a clinical trial of PD-1, LAG3 plus TIM3. And this is a triplet combination that is very tolerable. Actually, we presented some of the initial toxicity data at ASCO this year, and really no significant toxicities. So we're hopeful that some of these targets that have not shown a significant benefit alone or in combination with PD-1 can be a triplet assistant, as it were.
Speaking of triplets and thinking about myeloma, what about Ipi-Nivo or anti-CTLA-4 PD-1 LAG3 Omid? Is that that's being studied, correct?
It's being studied. It's also already
melanoma.
Accrued in melanoma. Already accrued. That data has not been presented. Based on some of that data in the phase 1 study, we've taken the phase 2 dose forward and actually combined it with sarilumab, which is an IL-6 inhibitor. And there's a clinical trial that's been written by Jeff Weber, and there are a couple sites are us, NYU, Dana-Farber, and Mass General utilizing this trial as a first-line trial. And it's based off of another first-line trial that we did, which was flip-dose Ipi-Nivo plus tocilizumab that showed very low response rates and significant, very low toxicity and significant response rates. Also, Adi Diab and others at MD Anderson have looked at full dose plus IL-6 inhibitors. We know that IL-6 levels indicate a lower response and a lower benefit to checkpoint inhibition. So there's a two-pronged action giving an IL-6 inhibitor. One is that it may supercharge your immunotherapy, and secondarily, it does decrease off-target toxicity. So that's a trial that has just begun and is accruing a fair amount of patients, and we'll have some data for you in a year or so.
So, Evan, as part of your presentation, you also talked a little bit about basal cell and Merkel cell. Again, can you kind of talk about when medical oncologists get involved with these patients, what their options are, and what are some of the things we've learned, particularly this past year, these couple of papers that you maybe want to comment on?
Sure. Let's start with basal cell. So basal cell carcinoma is an interesting disease. It's, of course, the most common human cancer. But most of the time, dermatology sees these patients and, excises lesions, and they're never to be seen again. But every now and again, either for reasons of neglect or just bad biology, the disease grows, so it becomes either functionally or anatomically or biologically unresectable. And so I think there, in answer to your question, is where the medical oncologist gets involved. There are a couple of options right now for patients with advanced basal cell that can't be removed surgically. One is a hedgehog inhibitor, and that is generally the first-line standard of care. The second-line FDA-approved agent is cemiplimab, and the phase 2 trial that you got on the top of the screen before was looking at health-related quality of life in patients who received cemiplimab after getting a hedgehog inhibitor. Unfortunately, the response rate was only about 24%, which is lower than we'd all like, of course. The good news is, though, that patients who received cemiplimab had high levels of functioning and low symptom burden at the beginning of this phase 2 cemiplimab trial, and actually that persisted, so the quality of life was generally maintained. I should say as a corollary that we hypothesized a few years ago that if you administered anti-PD-1 to patients with advanced basal cell in the frontline setting, not after hedgehog, but in the frontline setting, you might see response rates that are higher. And we presented this data at ESMO last year. We're seeing about a 50% response rate in patients with locally advanced basal cell carcinoma who receive frontline nivolumab. So this is a small study. We're still accruing, but we are excited about potentially increasing the likelihood of response if you use anti-PD-1 frontline in basal versus after a hedgehog inhibitor. So
is that
that's
something
basal
you
cell.
Is that something you offer to patients? Do you offer them the opportunity to get a checkpoint inhibitor? Or can you use it even? And would you use it before hedgehog?
We offer 2 patients on trial. The way the FDA has approved cemiplimab for basal or for patients who have had or who are inappropriate for a hedgehog inhibitor. So in some cases, that is in fact the case.
Yeah, like maybe you have a medical oncologist as your patient who says, "Listen, I see the toxicity. Give me a IO." But anyhow,
right.
How about? Right. I'm just looking at it, thinking, I don't know if hedgehog. You hear bad things about hedgehog inhibitors. Anyhow, what about Merkel cell? You have this one paper here of Nivo plus or minus Ipi, but again, anything else you want to comment on that? Anything else came out this year related to Merkel cell you want to comment on?
Yeah, Merkel cell is also a fascinating disease. It comes in 2 flavors, virus-related and UV damage-related. In both cases, we think there's a high immunogenicity, the virus-related for obvious reasons, and then the UV damage because it's so highly mutant. The tumor mutation burden is very high. But in any case, we're seeing high response rates to anti-PD-1 monotherapy up in 55 or so, maybe 60%. Range. The question that this study asked was, could you increase that response rate if you added anti-CTLA-4? And this was not a comparative trial, but there were 2 arms, and it pretty clearly showed that there was no benefit to adding anti-CTLA-4 per patients with Merkel cell carcinoma. One of the issues that remains out there is that there's a similar study that from the group at Moffitt that showed a 100% response rate in Merkel cell cancer for patients that got Ipi plus Nivo. So it's hard to make heads or tails of why these 2 results are so disparate, but for patients in my clinic, anti-PD-1 monotherapy is still where we begin, and if we need to turn up the heat, sometimes we'll add anti-CTLA-4 thereafter.
So I highly recommend you check out Omid's presentation and what he says about TILs. He referred to it before. I feel like we talked half the time we were talking about TILs. But I also want to ask you about this other agent, which I wasn't aware of, tebentafusp, or MTAC, Omid. What is this and what do we know about it? It seems really interesting, bispecific.
Yeah, so you're familiar with IMTAX because Kimmtrak was just approved for first-line uveal melanoma. It's a bispecific, so it's an antibody. I call it a Yenta-type antibody. It's a matchmaker or a double-sided plunger. At one side, it brings the CD3 cell, which is the T cell, together, which with another, with the tumor cell that's presenting a tumor-specific peptide in the context of HLA. So that's why you need to check in HLA-0201, because you need to have that HLA type to be able to present these proteins. Now, the CD3 side remains the same. The other side is different depending on the protein that you're targeting. Interestingly, tebentafusp was looked at in cutaneous melanoma along with anti-PD-L1 and anti-PD-L1, anti-CTLA-4. It showed tolerability. It showed a good durability of response and survival advantage. Now, what's the next step? This is a new IMTAC that targets PRAME. PRAME is a peptide that is presented on a multitude of solid tumors: ovarian, lung, endometrial, triple negative breast, and others. And in this study, we showed early responses, durability, even in melanoma that were heavily pretreated with checkpoint inhibitor, oncolytic, targeted agents, etc. We showed proof of principle, and in the lower left hand, you can see interferon gamma goes up, lymphocytes count goes down, lymphocytes traffic to the tumor, and we have seen responses and durability. The next step is combining them. These trials are combining them with chemotherapy in breast cancer and other solid tumors. It's combining them with anti-PD-1 in newly diagnosed melanoma, and also IMTAC combo, tebentafusp plus this PRAME IMTAC together in uveal melanoma. So what we're seeing here is the idea that immunotherapy in melanoma, nay, any solid tumor, is not just checkpoint inhibitor. It is T-cell therapeutics, which could be TIL, which could be these IMTACs, which could be CAR-T, it could be oncolytics. All of these things you can get together and try to improve response and durability. And because their toxicities somewhat don't overlap, they make a lot of sense to be looked at, and that's the future here.
So you've got to excuse me, you're going 1 minute over here because I got to do one more case in the chat room. Dr. Malady, who's in Roanoke, Virginia, I don't know, she's presented cases, all kinds of cases in the past, but she seems to have like a bunch of really interesting dermatologic cases. All right, Evan, here it is. I have seen a patient with argyria, large doses of silver ingestion just before Y2K. Apparently there was a myth and some people took colloid silver for fear of Y2K disruptions. I never heard that. His whole body is blue-gray. He has multiple large basal cell lesions all over the trunk and extremities. He wants to avoid IV. He's been on Vismodegib for 2 years with slow but steady response. Any thoughts or suggestions about this case, Evan? Have you ever heard of this silver thing?
Well, yeah, argyria, I mean, I can count on one hand the number of cases I've ever seen of that, but it's certainly a described condition. With regard to the basal cells, difficult to know whether the argyria and the basals are linked, although there certainly is some correlation between, patients exposed to various heavy metals and toxins and things. In any case, if the patient is getting Vismodegib and the basal cells are slowly melting away and the patient is tolerating Vismodegib well and isn't running into problems with muscle cramps and hair loss and taste changes and weight loss and things like that, I would continue. Some of the durations of response to hedgehog inhibitors, assuming the patients can tolerate them, are reasonably long. The last Sonidegib report, I think the median duration of response was something like a progression-free survival, maybe it was like 26 months. So it is very possible that this patient could have an ongoing response to Vismo. And if the patient is adverse to needles, adverse to intravenous medications, then I would stick with the oral meds.
So, yeah, what an interesting case. So, Omid and Evan, thank you so much for joining us today. I think we all learned so much, and there's a lot of excitement and all the new things that you're talking about. Audience, thank you for attending. Calling back next Tuesday. We were just talking about bispecifics. We'll see what Dr. Lee and Dr. Usmani think about teclistamab and other bispecifics and multiple myeloma. Be safe, stay well, and have a great night. Thanks so much, Omid. Thank you, Evan. Thank you very much.
Thank you,
My
Dr.
pleasure.
Miller.
Good to be with you.